from the American Academy of Pediatrics.
In the wake of the pandemic, chronic absenteeism has become a problem for schools.
New AAP policy offers strategies for keeping all kids in the classroom.
One way to keep children in school is to recruit the whole school health team inside and outside the walls of school to make sure that medication, whether acute or chronic, is not becoming a barrier to attending school.
Plus, new research shows a lack of early intervention for babies and children with sickle cell disease.
There are inequities in who we think about referring for early intervention and inequities in who we determine is eligible too.
These stories and more on Pediatrics on Call, the podcast on children's health for the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about safely administering medications in schools.
David.
Yes?
You are going to be very unhappy with me for this.
No. What did you do?
One of my children needed amoxicillin for an ear infection a few weeks ago, and I was really bad about dosing that medication for them.
Hey, I am not here to judge, Joanna. I think any of us who has actually had to administer antibiotics to children knows how hard it is. I mean, I'm so passionate about antibiotic stewardship. I always try to give really clear anticipatory guidance to families when I send a prescription. But honestly, getting all the doses in, it's just hard.
Yeah, well, luckily I was able to give all the antibiotics at home because they were on an every 12-hour schedule. But what if they had to be given at school? I can't imagine what sorts of reminders or protocols are needed when you're managing medications for hundreds of kids.
Imagine, too, if your child has a chronic illness that requires they get multiple medications a day, or anaphylaxis to peanuts where they need life-saving medical interventions immediately. It's a lot to think about, which is why the AAP has put out a new policy statement on just this: safe administration of medication at school.
Here to talk with us is Dr. Mary Beth Miotto. She's a general pediatrician currently working at Mattapan Community Health Center in Boston and is the president of the Massachusetts chapter of the AAP. Dr. Miotto, welcome to the show.
Hey, thank you so much, David and Joanna, for having me.
So we know being able to attend school both safely and regularly matters for a child's education. How many children require the administration of medications at school?
David, we don't know exactly the numbers because those aren't necessarily reportable to federal or state authorities, but we do know that the prevalence of health conditions in American youth range from about 25 to 43% of children. And so that means those children who are spending 6 hours a day, 180 days a year in the school classroom would theoretically require some medication during the school day. And with that said, we want to keep kids in school. And we are right now dealing with a moment where pediatricians, families, and schools are all trying to optimize health and learning as we adjust our routines after the pandemic. And chronic absenteeism is a big problem right now. And so if we think about the proportion of students attending schools with high rates of chronic absenteeism, we really need to think about one way to keep children in school is to recruit the whole school health team inside and outside the walls of school to make sure that medication, whether acute or chronic, is not becoming a barrier to attending school.
And when you looked at data for this policy statement, was the focus on public schools or did you include private school as well?
The data isn't as hardy as we'd really like. And we pulled in statements from the federal government, state organizations, the National Association of School Nurses, which was our partner on this statement. And in general, we were able to get an overall view from public and private. But this is an area that we really need to increase if we're going to get hardy data.
And when you're thinking about medication administration at schools, what inequities or barriers do you expect that children might come across to get those medications?
That's a great question. because we think about equity for children. And the first issue is children with chronic health conditions. Are they getting the medication from us, the community prescriber, in the first place? But there are a number of groups of students who are less likely to get the appropriate school health plans in order to get that school medication. Those are those with chronic physical or behavioral health conditions, those from historically oppressed groups, anybody facing barriers to care or education because of social drivers of health, and also children with adverse childhood experiences. Honestly, there are barriers for many children, and that's what's keeping many of them out of school. And the worry of their parents that they won't get the medication when they go to school can keep them home.
There are so many layers of people who need to be aware of what medication students get and then deliver those medications to the child or adolescent. Can you give us a rundown of the different professionals who are involved in this process?
Absolutely. David, one of the things we thought about when we wrote this policy statement was that very robust team. And the great part is the writing group, which included me as a general pediatrician with experience with school-based health centers, Dr. Brooke Balkan, who is a experienced school medical director from an urban setting, and Lori Combe, who is a recognized school nurse leader, is that we started making our list of who those players are, those partners we could use, and it's a very large list of team members. So let me go and try to hit at least a few of them. We have the registered nurses and licensed practical and licensed vocational nurses that could be the school nurse in any given school. We have mental health professionals inside and outside the schools. We have the school physician, the school-based health center staff, and then there's a group called unlicensed assistive personnel, and we'll say UAP, and they may be teachers, non-clinical staff, and coaches who are taught to administer medications when an RN or another licensed clinical staff member isn't around. And of course, we can't forget that a big part of the team is not just the professionals, but the actual parent who has to give consent for the medication to be administered wherever it's administered, and the student who needs to give assent. And that's going to not only protect their privacy and confidentiality, but also help to make sure that the medication is administered correctly, which is really our goal.
And in putting together these teams, do you think every school needs a pediatrician or an MD to be part of this process?
What we looked at was that just like having school nurses at any given school, there is a wide variety, much of it regional in the United States, of how many schools actually have a school physician or a school medical director. I would say that as long as you have the processes in place, you may be able to, as a school district, create some strong safety protocols that do not require always a pediatrician on staff all the time. Again, urban settings that have a lot of students may have a school medical director. I don't think you always have to have it, but you have to have those processes. Let's talk also about rural communities and communities across the nation. There is pronounced regional variation in school nurse staffing, where 88.2% of schools in the Northeast employ a full-time school nurse, and 78.9% in the South do, but only 59% in the Midwest and 33% of schools in the West have full-time school nurses. And that's an area that we as pediatricians can advocate for better coverage, because we know that students who have medication needs and have other chronic health conditions and needs really benefit from having a school nurse in the building.
And are there times when it's safe for the student themselves to give a medication to themselves at school?
That was a really fun exercise that our group did together in talking about self-administration and self-carry. Because as many of the listeners know, when we write medication orders for school administration, we as prescribers are often asked, can this child self-administer or self-carry? And I wouldn't say that most of us were ever trained in determining that. And yet, school nurses have strong rubrics to go through whether the child is developmentally able to do that, whether they have understanding of what the medication is, when they should use it. And it really is a pathway. And I personally came out of the experience learning from Lori Combe that we need to be talking to the school nurse. We may be able to add some insight and context to the school health team, but that there needs to be those rigorous processes inside the school to figure out in the middle of the day, is this child actually able to responsibly and safely administer?
I've never seen one of those protocols. Now I really kind of want to look at one and utilize it. That's amazing. How do state laws vary when it comes to delivering medications at school?
When we think about the laws that are important to understand, especially as a prescriber in the community, I want to always look at the federal laws, which include HIPAA, which we use quite frequently in medical practice, and FERPA, which is a law and set of regulations about privacy, confidentiality, and communication on the federal level for educational institutions. And those are somewhat the basis that every interaction with the school health team is governed by. And that's the communication realm, but it also means that how the medication is administered has to follow privacy. And then on top of that, we will add state laws. And as we all know, from state to state, there is variety of laws on reproductive health for minors, mental health, and privacy around those communications. But we really just need to look at communication as well as what nurses are entitled to do in that state. And those are called Nurse Practice Acts. And most of us, again, as pediatricians, were not necessarily taught in our training what the actual range of responsibilities are for nurses outside a hospital setting. And those are definitely variable by state. And again, in our group of authors, we had 2 Northeasterners and a Southern, sort of Western school nurse. And we found out that that varied so much that what we learned was that we need to know that as a prescriber and figure out within the 4 walls of our practices and then communicating to school, how are we going to navigate together as a team? Because we as community prescribers are part of the team with our partners in the school.
Well, talking about prescribing, are there certain medications that don't need to be prescribed but should be stocked in every school in case there's an emergency?
Yes, and we tried to highlight some of those medications in our policy statement, which would include emergency medications for anaphylaxis like epinephrine, emergency medication for asthma and other allergies, naloxone, emergency medication for diabetes such as insulin or glucagon. And what you'll notice is that some of these medications are very expensive. And that's a great burden on school districts. And that's an area that we as prescribers can help with some advocacy in that when the states are deciding what they will support in the school budget, they need to know that these stock medications are so important to the health of their students. We can also advocate for elimination of prior authorizations for instance, epinephrine or a rescue inhaler. We know that students need the appropriate dosing and access to the medications at home, and they need access to medications at school. And many pediatricians and prescribers run into difficulties having to do prior authorizations to send that number of medications and have them covered by insurance. So a lot of what we talked about also is recommendations to prescribers that we can all get involved, not only in the safe implementation of the medication, but also in advocating for better systems statewide to cover these emergency medications.
Well, listening to you, Dr. Miotto, is absolutely galvanizing me. And I imagine a lot of our listeners are going to want to get involved in their school's medication management policies. But how can they become advocates in this process?
I would say the first thing is just get to know the teams, right? Is that we were all trained mainly in hospitals, and we learned our teams, and that made us stronger advocates and practitioners. Then many of us went to outpatient settings, and we get to know our teams. But we can't really know as community prescribers what the challenges fully are, except when we talk to those team members in the school. And we can advocate with the information that we share so much more powerfully. And that could be as individuals going to school board meetings, speaking to school administrators as an expert in the area, especially if it's on asthma or anaphylaxis. Or it could be getting your state or the national organizations together to advocate. But I believe that, as in any advocacy, the stories we tell about the students we take care of will go a long way in letting non-clinical decision makers understand what the barriers of care are, and also realize that right now, where chronic absenteeism has risen so much in the past few years, that we can all come together around students with any health conditions coming to school if we create safe medication policies.
Well, this knowledge is certainly going to empower us all, and there's so much more we could discuss on this topic. So that's why everybody should go read the policy statement. But do you have any last takeaways for the administrations of medications in schools?
I do. There's so much, and we really couldn't, in that policy statement, hit on one recommendation. We had a list of 11 practice-based recommendations and 12 advocacy recommendations because it's a big topic. But I'd really say that in this day and age where there's a lot for both community prescribers and school nurses to be doing on a day-to-day basis, they really have so many responsibilities, and we're together in wanting child's health to be the key priority. But the main takeaway, I would say, is that we can share so much between each other with bidirectional communication. And with the family's consent, always, and hopefully the family's cooperation and input, we can provide, as community prescribers, clinical and social rationales for in-school medication administration. What sometimes feels like cross purposes can turn into a great outcome. So I will just give one example. A school health team may have developed departmental goals to encourage students and families to manage their own medication at home. The school health team may not have the details that make school administration of, say, an ADHD medication or an asthma controller medication essential in the school. When I devote 5 minutes to a chat with a school nurse about the social drivers that may be barriers to that morning inhaler and the controller, or I could speak about the side effects that a student can avoid by taking their stimulant medication after their school breakfast, I'm rewarded with positive outcomes for the patient, and I've actually made less work for me and for the school nurse. So when it comes down to it, if the only takeaway you come out of with this updated school administration policy, then it would be try to pick up the phone, find a secure portal, secure chat, secure fax if we're in 2024, but faxes are still used, and try to up your communication with the school health team. And I think that if all those members of the team are on the same page, school is going to be a safe and great learning and social experience for the students.
Well, that sounds like we can all do something to help with that safety and stability. And Dr. Mary Beth Miotto, thank you so much for joining us today.
Thanks so much. I love listening to the podcast on my long commute into Boston, and I will continue to be an active listener.
To read the policy statement, Safe Administration of Medication at School, visit our website at aap.org/podcast.
Coming up, we'll look at why children with sickle cell disease should be considered for early intervention programs. A big part of my job is that when I discharge a premature baby from the hospital, I refer them to early intervention services. In fact, I refer most infants with a prolonged NICU stay to early intervention.
Well, that makes sense. Here in North Carolina, we also use early intervention services for our most at-risk children to get them engaged in the services they need in infancy until age 3 when the school system takes over.
While I think there is no doubt early intervention can be helpful to children, it's not always clear which babies or kids need it.
I know. It's always a little tricky for me to navigate in the outpatient clinic. There are state guidelines for it, but knowing exactly whom to refer still requires some clinical judgment.
Well, there is one doctor who is really thinking about one specific patient population, those born with sickle cell disease, and making sure they get early intervention services to help bolster their development. Her name is Dr. Alexis Williams.
Dr. Williams is a pediatrician currently in her fellowship in hematology and oncology at the Ann and Robert H. Lurie Children's Hospital of Chicago, and here with us today to talk about an article in Pediatrics entitled Closing the Equity Gap, Early Intervention in Sickle Cell Disease. Dr. Williams, welcome to the show.
Thank you so much for having me.
So, Alexis, I'm pretty sure many of the people listening are acquainted with early intervention, but can you give us a brief overview of what it is?
Absolutely. So early intervention is a governmental program. The federal government allots certain funding to each state across the United States to institute programming that supports the development of infants and children within that state who have certain disabilities or developmental delays. They also suggest but do not require that states include children who have conditions that put them at risk for developmental delay in the future.
So knowing that, who typically gets referred to early intervention services?
So often we think of patient populations such as premature infants or people who have documented developmental delays. So kids we see in clinic who have a speech delay or a gross motor delay. We often also think of infants and children with autism diagnoses or other diagnoses who get referred to early intervention services. And I think often we, as pediatricians, haven't thought necessarily as much about those conditions that might confer risk in the future.
And why is it that patients with sickle cell disease need early intervention services? Is it something specific to the pathophysiology of the disease?
Yeah, and so this has been something that researchers have been thinking a little bit about. Some hypothesize that disease-specific complications such as stroke, other neurovascular complications associated with sickle cell disease could be reasons that this patient population is at high risk. But there are also other people who think that even just the state of anemia can have effects on the brain and confer neurocognitive risk and developmental risk. And other people think it could be completely separate from the anemia or the vascular complications of sickle cell disease. Sometimes people also have hypothesized that given that patients with sickle cell disease are often Black or African American patients, and in this country, a lot of Black and African American children due to racism in this country, have socioeconomic or social determinants of health at play, which also likely contribute to neurocognitive risk in this patient population.
Now, you mentioned that it's a federal program, but how varied are state interpretations of who gets early intervention?
Yeah, so early intervention is a federal program, and funding for it comes from the Individuals with Disabilities Education Act, or the IDEA. Through that, states get some federal funding to support an early intervention program, but there are very few guidelines outlined by the federal government as to what that program needs to entail, who they need to include, and what services they need to include. And so it's up to each individual state to interpret those loose guidelines and to fill them in kind of how they see fit and how their funding and their budget works with that program. And so because of that, there is a lot of variability between one state to another in terms of who is eligible for early intervention, also what services are offered through early intervention, and also, too, how much money, if at all, is on the family or the participants to put in for early intervention as well.
So what is it about current enrollment in early intervention programs that fuels inequities in access to services?
Yeah, I think there are a lot of different factors that contribute to inequities when we talk about early intervention enrollment. I think the first, as we alluded to, is all of the different eligibility requirements between the states. And so a infant or child in Indiana, for say, might be eligible for those services in Indiana, but may not be eligible for services next door in Illinois. And so because of eligibility requirements, there is a lot of inequity that stems from that. I think further, there are inequities in who we think about referring for early intervention and inequities in who we determine is eligible to. And so when we think about how at least certain at-risk populations have been determined to be eligible, I think Colorado is a really interesting example of that. They have a board of medical professionals and providers who sit and discuss different disease processes or diagnoses, and they sit and determine if that disease or diagnosis confers a high enough risk, in their opinion, to then grant eligibility for infants and children with that condition. And so I think anytime you get a group of people in a room to talk about who we think should have access to something or not, I think also lends itself to be an inequitable process.
Do you think this is an example of a place where we could correctly apply the terms systemic racism or intersectionality?
I do. I think that term could be applied across many different sectors of our society, and this is another example of that. If you look at many different states who do have publicly available lists of conditions that have been determined eligible under that at-risk category, you often see diagnoses that affect predominantly white populations, and unfortunately, diagnoses like sickle cell disease that affect predominantly Black and African American populations are definitely lacking, unfortunately.
And which states currently offer early intervention to children with sickle cell disease?
There are currently 5 states in the United States who have a publicly available list of qualifying medical diagnoses under that at-risk group who do list sickle cell. So that's Michigan, Mississippi, Ohio, Tennessee, and Virginia. There may be other states that also do include patients with sickle cell disease, but they don't have their list publicly available. In doing some of this research, I actually did try to contact a lot of the early intervention divisions across the United States. And like many other governmental agencies, the responses aren't always brisk. And so it was a little bit challenging when they didn't have a publicly available list. But of the 25-ish states who do have a publicly available list, only 5 of them included sickle cell disease.
So what can pediatricians do to advocate for access to early intervention for sickle cell disease in all 50 states?
Yeah, so I think first and foremost, just having sickle cell disease or infants and children with sickle cell disease on our minds as far as patients or infants and children who could benefit from early intervention services, I think is step 1. Step 2, for pediatricians who do practice in any of those 5 or maybe more states that do consider sickle cell disease as an at-risk condition that makes a patient eligible for early intervention, to refer early, to refer thoroughly, and refer often for those patients. And then for all those of us who practice in the states that don't consider sickle cell disease as a qualifying diagnosis, I think there is a lot of room for advocacy. We obviously, as pediatricians, have a strong voice, and so lobbying and going to testify and sharing testimony of how early intervention programs can really impact the development of infants and children, I think would be a strong force to the powers that be to consider infants and children with sickle cell disease as people who could benefit and would benefit from these services.
Well, it seems like by drawing attention to this problem and defining it, this paper serves as a great first step in mitigating these health inequities in the treatment of sickle cell disease. Do you have any takeaways for our listeners so they can further this paper's mission?
Absolutely. I think certain takeaways are, and at least for me and many of the other kind of colleagues that I've talked to, is to really have sickle cell disease at the front of mind when thinking about conditions that do confer risk for neurocognitive dysfunction and developmental delay. I think remembering that we do have a lot of power in our voice in terms of when we talk to policymakers, when we talk to governmental agencies, and also when we talk to families too, being able to really speak on the process of early intervention, what that looks like, how that might be helpful for a child, I think are really strong ways to leverage this tool to really support the development of infants and children with this diagnosis.
Well, Dr. Williams, thank you so much for joining us today to talk about this important topic.
Thank you so much for having me. It's truly been my pleasure.
To read the paper, Closing the Equity Gap, Early Intervention in Sickle Cell Disease, visit our website at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Well, Christy and I have been training for what is for us a long bike ride. Now, real cyclists will scoff at this, but it's a 34-mile ride through the country for the Burgaw, North Carolina Blueberry Festival. It's called the Tour de Blueberry because that's French. But it is really a beautiful ride through all these fields, and you see corn and cows and horses and a bunch of other cyclists. And it's this tremendous community event that we always enjoy doing. So that was a blast.
You guys are so fit.
Oh.
My Say Ah is that it's sort of the end of graduation season. And so we got to do the pre-K graduation and the kindergarten graduation. I have to say, David, it's not like your high school graduation, teenage year graduations, but it's really cool to see the kids getting older. And it's sort of breaking my heart, but making me happy at the same time.
Aw, did they wear the little mortar boards?
Oh, yeah. Oh, yeah.
I love that.
Very adorable.
That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll talk about new contraceptive methods.
We'll talk to adolescent medicine specialist Dr. Mary Ott. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.